he had hives, and I cannot tell whether it's a drug reaction from one of those, which one it was, or something else. So I had to stop it. I stopped it. I intubated him. But then now, in retrospect, when I think about it, it may not be, the hive may not be from the drugs. COVID actually does cause a dermatologic manifestation that looks just like that. It could look like hives.
Wow.
So that one, that's my limited experience there.
Oh, okay. How about you, Minh? You have a, well, first of all, are you actively seeing patient right now with COVID, or, and then can you share with us what's going on, Minh?
So I kind of lucky. I'm not in, Dallas is not in the host center right now for COVID yet. I don't know the shelter in place order do any different, but initially I think the peak they expected to be mid April, but now it's pushed back to the early May. So I hope it's worked. I hope that we can manage. And the second thing is that I'm not directly deal with the patient, like inpatient or like the intensive care and Bao. But I'm watching, and obviously it's kind of like curve stick going up in Dallas right now. Hopefully it's plateau out soon, hopefully. But it's all, we have like bracing for impact, just like the plane crashing. We just try to just hold ourselves up and try to see what's gonna hit us. But just wait and see.
All right, so let me go to Tayna, and then I go to Bao, because I need to ask you a couple more questions. This is great. This is one of the I to ask you about. Tayna, can you hear us, and you have any comments with COVID-19 so far?
Actually, for me, because pediatrician, I'm not haven't encountered anything significant yet. But I've been following the news. Actually, one baby, a 7-week-old baby, just died because of that. I'm kind of anticipating and waiting, you know, when it starts hitting the pediatric population. I hope that it doesn't. It will not affect significantly. But I'm preparing, you know, you cannot really predict or say for sure that we will not be affected, you know, pediatric population will not be affected, because there's actually some cases already. So.
Wow, that's, so what is your comment on kids? What is your experience?
So you mean by the, with the Plaquenil, or you mean like in general with the COVID-19?
Well, in general, let's start with this first. Do you see kids, they have the same manifestation as adult when it comes to COVID-19?
Well, I don't know, we have enough information to say, but in general, what I've read is that most likely they actually do get infected, just like all of us, but the disease process may be so mild that it is either subclinical or very, very so mild that you think they had a cold or something like that, and not severe. Because if you look at the people that get tested, actually, I don't know about the statistics elsewhere, but I'm well aware of statistics in San Diego County. So 34% of the positive tests in San Diego County are in the very young, not the pediatric group, but a very, very young group, like 30, in the mid-30 to 50 years old. So they're not immune. That's a 34% of the positive tests. So the younger people are still can get it. It's just their disease process is probably mild or either subclinical or so mild that they think it's something else.
Wow. So let me change the mic to Dr. Toll from Detroit. He's actually on the epicenter right now. So Long, can you share what's going on in your hospital, and are you okay so far? Share with us.
Oh yeah, it's been crazy. This is definitely nothing I've encountered. You know, it's when I hear from New York City, I'm thinking, wow, I wonder if that's going to happen here. And then Detroit all of a sudden became like the third highest or fastest growth in the number of COVID cases in the country, behind New York and I think Seattle. But in my hospital, we pretty much, like I said earlier, we have about 180 to 200 ICU beds, and they're almost all full. And we started 3 weeks ago. I don't think we reached our peak yet. I expect us to reach it next week. My unit has 40 beds, and we halted any elective surgery, no even heart lung transplant, ECMO, VADs, none of those things are being done. So all of my patients are now COVID. So like today I had about 35 patients, and I would say 30 of those were COVID positive, and most of them are intubated. And then we're converting the our OR operating rooms to ICU rooms so that patient could be admitted there. And then we're converting a lot of another sister hospital site to care for COVID patients. So like all of them MICU, it started with all the MICU beds, and we had about 80 of those. Those got filled in the first week. And then it went to the surgical unit, and we have about 40 of the beds there, and they got filled really quickly. And then now it came to my unit, and even our neuro stroke unit is being switched over to COVID. So like I've seen, and this is kind of, it does match with what some of the data that's been published in China. Like even young patients are getting really sick. Like the first week, I have 32, 39-year-old patients that are more sick than the 50, 60-year-olds that I've had. But now, like of the 30 I have, they're all pretty consistent in the 30s to 60s that are pretty sick. They're all intubated, requiring mechanical ventilating. We're proning about half of our patients. They're requiring, what's the weird thing is they require so much sedation, so much so that like they should have had respiratory depression, if they were on the ventilator, but they're waking up, they're self-extubating. So that's the thing is like we're concerned with the normal sedation protocol we have, that we figured that will be more than enough. But for some reason, these patients, even though most of them are just naive, opiate naive, they have maybe diabetes, hypertension, and for some reason they need so much sedation. So we're switching our protocol to doing a deep sedation, like a RASS score of -4 or 5, where they're just totally out, so they don't, at least the initial 12, 24 hours, so they don't self-extubate. And then once we see that they're improving, then we would go to lighter sedation. But we found out a little too late, because I think we had about 3 or 4 that self-extubated. So that means nursing, the team got to run back in, risk, getting exposed, and then try to reintubate the patients. So and then my worry is by next week, when we run out of the sedation, because they're using so much, what are we going to do? And I asked that question, like New York wants 30,000 ventilators. Well, what are you going to do with 30,000 intubated patients with no sedation? It's like doing a procedure without anesthesia. Like they go hand in hand. You can't intubate a patient who has ARDS and not give them sedation, or paralyze a patient to treat, to prone them or to treat the ARDS with the ventilator for days without sedation. It's kind of crazy. So that's what I'm stressing out about. And then for myself, I wear the mask at all time now, and thank Minh and Nguyen for sending those masks. But I basically strip down in my garage. Nothing gets in the house. I put my shoes, I Lysol spray everything, and then I go straight to the shower. And hopefully I don't expose my 1-year-old son and my wife. So that's the kind of like every day. If I've noticed myself touching my face. I used to do that a lot. Like I'm in right now touching his face. I do that a lot. Like touching the doorknobs. I'm constantly thinking where I'm going to catch it. So that's the other added stress to it. It's kind of like you're in the hospital. Everywhere I look, my entire, the whole unit's filled with COVID patients. So whatever surface you touch, there's a potential risk that the virus is there. So that's stressful too. Yeah. So.
Well, so let me ask you this long. How would you anticipate this? How long it will last, and how would you sustain yourself to go that?
Oh, I think this is going to be with us for a while. I don't think this is going away anytime soon. I don't think the only way that I would feel relaxed and comfortable is if it's like the measles or some other things that just kind of we eradicated, with vaccine, but that takes years. So, we may reach our peak here in Detroit maybe next week, but it doesn't mean we don't risk getting it, right? So it may take a few more months for things to be under control, but then another city is going to be a hot spot. And it's just going to go from state to state, and we may even last till fall. And then who knows, there's talk about what if this virus potentially mutate, or can you get, if you're re-exposed to it, can you get can you get sick again from it? So there's a lot of questions that we don't know. Although I did hear from a colleague of mine that he read somewhere that the rate for mutation in these viruses, or at least this strain, is about 10 times slower than the flu. So it may take a little bit longer to get us, the second surge of sickness from it. But at least for us, I think we probably need, like the governor Whitmer from Michigan is anticipating we may need to go to June, like keeping the lockdown to June. But hopefully then we don't have to do that. Yeah, but I think this summer is going to be crappy because I don't think people are going to be doing anything.
So, Dr. Luu, have a question for you. How long? What's the average time of patient on the ventilator? By the way, just let you guys catch up. I have Dr. Bao Luu, who's an intensivist, Dr. Minh, internist, Tayna, pediatrician, and Long as ICU specialist. He's Dr. Longto. He's cardiovascular clinical pharmacist. So Long right now, by far, by no means, you are the champion of COVID-19 in that group. Okay, Long. You like seven. This is the number that nobody ever want to get. And I also have Dr. Hongvor from Massachusetts just joined us lately. But just to tell you, this is so cool because we share real. And let me share with you my experience. As consultant, I see. I rarely see COVID for now, but actually it's on my way, and everyone in my team already scared because, like Long said, it's everywhere. It's on the handle, it's on the handrail. So let's go back to Dr. Bao Luu. How would you avoid that? Because I'm sure you see it every day. And
so just like Long said, it's a very scary thing. I'm fortunate that I'm a little behind. So I'm hoping that we will a little bit more prepared here in San Diego. So, there's really no other way around it. I mean, at work, you potentially can be contaminated at any time. And so along the thing we worried about the most is not really us getting infected. In a sense, I'm kind of resigned to the fact that I probably will get infected at sometimes during this course, because like Long was saying, it's not going to go away in a couple of weeks. I think we're anticipating probably a couple of months. So it's possible. It's very, very possible that you can get infected. What we worried about is that we worry that we will bring it home and infect our family. So what I do is I'm lucky. I have a bedroom downstairs, and that's where I'm gonna use. Right now, that's where I am right now, and nobody comes into this room. I come through by the garage, and just like first of all, I change or shower at the hospital right before I leave, so that I get into my car in clean clothes. And then I go into go through this room through by the garage and to the side door, and so nobody goes in this room.
Something from Massachusetts for 1 second. Welcome, Dr. Bo, and this is a informal COVID-19 talk. Okay, so but we have a lot. We have intensivists, we have internists, we have ICU specialty here. It's so hard. Okay, so Home, tell us what's going on in Massachusetts right now. Massachusetts.
It's not a good year to be an intern because they reschedule everything. The whole structure is, the XY, the ambulatory is all out the windows now. So we have a lot of cases in now in Massachusetts right now. In Boston, there's a lot more, but in Worcester right now, they have 64 cases, all of them in the ICU. I'm just counting the ICU cases right now. There are more than 200 cases in Massachusetts already. They added more unit. They converted a lot of floor to ICU level now. They also, converted a lot of nursing home, and then they just bought out big DCU places and converted it into a COVID unit only. So we are trying to accommodate the increase in number. So the number has jumped up from weeks, quadruple, from the first week was only 12 cases in the ICU. Now they have like 64 cases in the ICU. And most of them are pretty young. The youngest one that we have is 31 years old. So that's
Wow.
like younger than me. And he's not doing well neither. So it's quite scary. Yeah, so a lot of our interns are like, we're running out of PPE pretty quickly. We only allowed to get one for a whole week now. We have to put into a brown bag and they have to like disinfect it. It's a mess right now. But I think Massachusetts is getting more PPE from China. I think Pagers just bought like 1 million of them from China. So that's good. We're getting some relief from that. But yeah, it's getting scary. A lot of people just don't know what to do. Everyone's out there buying N95 mask. I don't know why, like everyone from the public, a lot of Vietnamese nail salons and, the market, they're just buying all the masks, selling a lot of masks, like really high price. I don't know, like it's not even, ethical anymore, but, not going to go into that, but it is getting scarier. And yeah.
Well, so I'll get back to you in 1 second. Home, this is great. This, especially from a intern perspective, this sounds crazy. Let's get some science here. Does any of you know the statistic of healthcare worker? How many % will get infected?
Okay, so I do know a little bit. Okay, so if you look at the statistic in Italy, about 8% of healthcare professionals, that include nurses and doctors, got infected. But at the epicenter in Bergamo, when it's broke out in the city of Bergamo, 20% of healthcare professionals were infected. Bergamo. In China, the statistics is very, very difficult to pinpoint. In Wuhan, at one hospital, they reported like 80% of the healthcare provider was infected. I don't know if that's true. So it's very hard. But here's the good news. University of Washington, they they just screened all healthcare worker weekly from time when they got hit. And they screened 1,000 healthcare professional. They got 7 positive. And of the 7 positive, 6 was community transmission. Only one got it at work. So that's actually encouraging news for the U.S., meaning if you are using PPE and you being careful and following everything, chances are you're probably protected.
And Bao, what you described earlier about being prepared, that was us. That was me last week. It was like the calm before the storm. Everyone was saying, like, I had 12 patients in my unit, no surgical cases. I'm like, wow, this is great. But in the back of my mind, I know in 2 days it's gonna hit. And once we started admitting, like, it was crazy. The next morning I come in, every half hour, my charge nurse would get a call, and I'm hearing, and she say, okay, we have an COVID rule out, being admitted, COVID rule out, straight from the ER. It's just constant admission of COVID patients. It's crazy. Just don't know where they're coming from, but they're all coming in.
Wow. Well, so let me ask you guys one more question about this, and I know that I don't want to keep you that here, but testing, okay, this is crucial. And Bao, what is your testing situation? And let's go along and see how would you answer testing?
Actually, we are pretty fortunate. The limitation now is actually not so much the access to the test, but a lot of time it's basically swab equipment, personnel trained up to run the machine. So we brought RT-PCR in-house very early on, and we run our own hospital can run 60 tests a day. That's in-house. But we also signed a contract with Abbott just as soon as they got approved.
Wow.
So we'll probably be up and running next week with the Abbott test.
So you're saying that your testing is likely PCR test, right? And Bao, this is not antibody test.
No, so antibody test just got approved today. It's an antibody test. Is 3-stripe. It's probably looking for the control and IgG and IgM, or IgM and IgG. I don't know which sequence it goes in, but there's a big disclaimer that there's cross reactivities with other viruses. So first of all, the studies show. I've read 2 studies. One was in the Lancet, and the other one, most recently, just in the Nature, just 2 days ago. So IgM 50% will rise within 1 week, and IgM will peak at 3 weeks, and IgG will rise and then plateau out. That's a Nature paper. So there's going to be a lot of false positive, false negative. If you test positive on the serum serology, if your symptoms within a week, your IgM, IgG might not have risen yet, and it will be false negative.
Sure.
And if you even test positive, there's cross reactivity with other coronaviruses in this particular test. The tests that they do, then it's useless, really. The testing is the serology has been approved by FDA just like a couple of days ago.
Okay. So we'll get back to you in one second. And then, what if your patient want to get tested? What is your answer?
Yeah, so it's different setting. I'm like outpatients right now. So we divide into several groups. So for those who just would like, I want to test, then they have the drive-through to a different facility. They will have some questionnaire for them. Of course, if I'm totally fine, I want to try to just want the test, they're going to turn me away. No, you're not qualified to do the test. If you meet the criteria on the questionnaire, then okay, you can keep driving, and they swap you, and you go home. They will contact you with the results in around 3 days or 5 days. That's for the general populations. In-house, they tested with results on the same day. Right now at the moment, the number of cases, the test is kind of limited, so the only result for in-house. But I heard that pretty soon, I think sometime next week or next 2 weeks, they will improve to a newer technology, and it's going to be same day or 1 day later. So it will be faster, and they ramp up the volume also, so make it easier for us to test more people. Right now, we have to really make sure the patient likely meet certain criteria to get tested. And in another way, the treatment is for mild case, just stay at home and take care of yourself. So whether it test positive or negative, you still stay at home, take care of yourself, and that's a shelter in place anyway, so they're not going to go anywhere. So yeah, it's the situation right now in Dallas. We bracing ourselves right now.
We'll have more insight from Dr. Hong from Dallas also, but also pediatrician. But let's go to Long real quick. Long, how is your testing at the hospital? I'm sure it's really fast right now, but can you share with us your situation right now, Long?
So when we first started, there was a delay because we had a lot of tests and not enough, I believe they said not enough of the media to run the test. So it took us about 3 days to get the results back. But now I think we get it back pretty quickly. Within, I would say 12, 24 hours, we'll know right away if the patient's positive or not, which is important because it helps us to decide whether we're going to treat the patient or not. And that's key. And I feel like what we've been shifting toward with our treatment is the earlier the better. But the testing so far is okay. Like for employees, they have this drive-through that we can do. my previous resident who works there now, it took her a while, but then another colleague of mine is being tested now, so I'll have to see how long it takes for his result to come back. But for our patients, I think the turnaround time is pretty quickly.
Wow. So anh Bao PCR, anh Minh prefer to dry test too, and now you still PCR, right? Not yet antibody. Let's go to Dr. Hung.
Yeah, PCR. Yeah.
What test let's talk about testing situation in your clinic. And
so we drop it so slow, and then we actually do 4 situations. We screen them ahead. They have COVID risk, like they have exposure to COVID patient or suspected COVID patient. We send them to another clinic in the system, so they only do COVID over there. And now they do the testing with the antibody test.
Okay, so now PCR and antibody. Okay, that's good.
Because the PCR takes forever. It takes like.
Hung, how is Massachusetts? How's you guys do testing right now?
So we do PCR. At first, it takes 3 days, but now we actually have a lot of testing center right at Worcester. And I know some place in Boston, they use a lot of their labs to actually run the test. I think BU does the same thing. They convert a lot of the stem cell therapy labs to convert to like COVID testing only. So they're much more faster. So right now, the turnaround time is 24 to 48 hours.
We talk about testing. We talk about how to protect ourselves from this COVID-19. You know what? One thing is, it's once you get it over and positive, you can say, "Hey, I'm COVID positive. Just do a tattoo right here."
That's actually the ED docs. They have that mentality. You know, there's a few that I know is positive, and they just feel like I'm invincible now. I can do anything now.
The next 10-15, I leave the discussion to you guys. This is, as I said, not a formal VietMD doc meeting, but rather than a COVID personal experience share. And by the way, I will upload this later now, group of board of directors, so other people can see and can share. But I think this would be interesting if you guys, so next month I would rather focus more on COVID, and I think at that time, and Bao, you will have a lot of patients. I anticipate the champion, not like Dr. To at the moment. And then Hung, by the way, Dr. To have 37 COVID patients by himself. So he's the champion, not VietMD doctor right now. But I don't anticipate all of us will be, but I think next month. But let's leave the discussion right now. I'm free, whatever you want to talk, just raise your hand and share and yes, Anman.
Yeah, let me ask a question first. So Bao and Long. First thing, yeah, we know that the influenza kill a lot of people, but people get sick and die from influenza too. Any difference when people in the ICU get really sick and die from influenza and die from the COVID? Any difference? Okay,
so we've seen influenza. I survived the 2009 H1N1, and in the 2009 H1N1, my hospital we surged and we overfilled the ICU, and we set up in the ICU in the regular ward. We had the intubated patient regular ward too. But even in the worst influenza season, the mortality rate is not that high. Mortality rate from influenza generally is about 0.1%, so 1 in 1,000. And just like with coronavirus, I mean, usually it's elderly patient, multiple comorbidities. The statistics, what we know, the literature is that for this particular coronavirus in the U.S., this is Seattle experience and other places. Mortality rate, if you're below 50 years old, is about the same as the influenza. It's 0.1. But between 50 and 60, it's 0.6%. And between 60 and 70, it's about 6%. And when you above 70, you're in the 80s, it's around 15%. So it's really a exponential growth like that. So it's drastically different than influenza in that sense, and it's probably more contagious than influenza, they are not the number that how many patient you can infect it. If one infected patient is probably higher than influenza. And on top of that, all the hives, all their hypes about this, it makes it everybody's extra nervous. You know, and you know the care for the patient is a lot more difficult. Okay, the example last weekend where I had to take care of those two patients. Normally, when I go into the room and do an intubation, put a central line and arterial line in for these patients, no more than half an hour. Okay, for all three procedures. I'm not bragging, but you know, it's because I do this a lot, and it's become, you know, if you do it at night, you want to do fast so you can go back to bed. So you get good at it, so you don't stay up all night. But for these patients, it takes at least 2 hours because you're in the isolation room. You put a sterile gown on top of your gown, so you're hot, and double gloves, and everything. You say to the nurse, "Could you get me a towel?" All right, and then she has to go to the door and yell outside, "Dr. Luu, need towel," and then somebody run to get the towel and come back and sit at the door and come in. So normally that take you 2 seconds to somebody come grab you a towel to just clean the patient up. But now it become 2 minutes. So everything is extra long. And the care for the patient is a lot harder than influenza. I want to ask Hong a question. We have residencies in our program too. And the PPE is a big deal because we're running low. So we're limiting right now of how staff are not exposed. We keep them away from the COVID patients. And I want to know whether other programs are doing the same thing.
So at first they promised that they don't want us resident or interns to take on any COVID patients. But now as you see, there's 50, 60 patients in the ICU. So that's impossible. They don't have people, they don't have intensive, to take care of all of them. So now what they do is they have resident and interns, but they have one intensivist. So they do like a FaceTime in. So if you have questions or, you know, anything, they can FaceTime in into the camera into the room, and they can ask you to do like a physical exam or whatever they want you to look at. Then you can, you know, tell them what's going on, and they would tell you what the advice is. But usually we have like a 24/7 intensivist is just watching the camera for the resident interns. So it's tough, but you know, you can't limit the exposure anymore.
Right. So this is part of so you being used as part of a surge plan.
Yeah.
So this is what they're talking about, is that they're going to build pyramids of care like this, pyramids of care. And on top, you may have an intensivist supervising the whole team. Mm-hmm. Then you may have, then after that, proceduralists, anesthesiologists, vascular surgeon to go in to intubate, put lines in for you. And underneath that, you may have hospitalists, endocrinologists, dermatologists, rheumatologists, who are going to have to come in to see this patient. And each team with a pyramid like this, you might have one intensivist. Normally, you know, if normal census, I carry about 12. I'm very spoiled. I don't have to carry 30 patients, but usually 12 patients. But with the surge plan, when they build a pyramid like that, I might be supervising, you know, 30, 40 patients, but with the helps with extenders, and they're using in this case, Home was giving an example, basically the house staff as the extender below here. So that's probably going to be the plan for all. I mean, each hospital have a different, I mean, and
one more question if possible.
Okay.
Maybe too long then. I listened to your talk earlier, Wynn, and I got curious about the BCGs too. So Long, you have a lot of patients. So you see any difference between like Asians who likely have BCG and the Caucasian who likely not having BCG? Any experience about that?
I do agree that the flu, it's way different. It's not anywhere close to what I've seen with the coronavirus now. I mean, all these patients eventually develop ARDS, and that's extremely difficult to manage. And so I have patients now who are intubated for at least a week. We only have like 1 or 2 that are extubated so far, and so I don't know. It doesn't seem like there's any. I mean, we know the risk factor like hypertension, diabetes, and things like that in older age, but I'm seeing a lot of just, you know, any age group that can get really sick. And it's too fairly early for me to distinguish by, you know, if there's a difference in race or any other sort of risk factors. But for now, they're all, to me, seem pretty sick. And then comparing this coronavirus to the other flu virus. So.
That's a great topic, I mean, because I don't know if Anh Hưng, as a pediatrician, you can comment more on this, the BCG vaccine. The epidemiology study, I'm sure some of you already see that the mortality rate for those countries with those vaccines, it's about 10 times lesser than without the vaccine. So what is your comment on that, Anh Hưng, as a pediatrician?
So for this, I don't have enough information to tell what the difference, because most of the patients in US based, they don't have the BCG. But only the patient from like migrated from like Asia, like Vietnamese or some other country, they have the BCG, but it's not enough to, you know, for me to tell which one is better, which one. I actually have the expo to the tuberculosis in Vietnam. So when I test my test is always positive. So if it is a good thing, it may be good for me. So, but it's not enough for me to tell though. But most of kids in the US, they don't have it. So, and then we don't have enough in Asia to compare. So it really, you know, I cannot tell.
And Bao, what is your comment on that, the BCG vaccine? What's your thoughts on that?
I don't know enough yet. I have to do a little bit of reading and learn about the science behind it. But I don't imagine it's going to be big difference. I mean, if just on the global overall look, the mortality rate in China is horrendous. And there's reports are saying they are underreporting it. It's looking at that. If you believe the series out of China in the New England Journal, mortality rate is about 3.4%. The first series out of China, that's already higher than what we're seeing in Seattle. It's hard to. New York is probably not a good comparison right now because they're in the mid of it. And I have friends in New York. I actually went to medical school in New York, so I have a bunch of friends still in New York. And what they're saying is, they don't have enough tests. So unless you're in the hospital being admitted, then they send you tests. If you come to the ED and they're intending to send you home because you're in a mile, they don't test you. So then the denominator numbers is much smaller. So that if you calculate mortality rate based on that, mortality rate is going to be really high because they don't have enough tests. They don't test people. So right now it's probably unfair to use New York, but if you use Washington State, then the mortality rate in Washington is already much lower than what's reported in China.
So obviously this is the area that we need more study and we need more, but that's a lot of interesting discussion. Any comments, feel free to jump in. But what I'm thinking, maybe in next couple of weeks, and Bao and Long, actually those two guys, and then other, I'd like you to invite you all come again, and because this is a group of Vietnamese doctors, we can share a different personal experience with COVID, and hopefully we can learn from each other. I learned a ton of today. I don't know how you feel, but especially from Anh Bao and Long and then Minh and then other people. So comments, please.
Can I ask Anh Bao and Long a quick question? So for some reason, a lot of the patient in the ICU, the COVID patient, none of them are Asian. So is that because we are more protective? We are more we wear a mask compared to like other people? Is that why? Because I don't know why, but aren't we supposed to be a higher risk because we have like, the ACE2 inhibitor, the receptor is more than the, Caucasian people. So I just want to see if that's a trend for you guys.
I'll get back to you next month when I see more patients. But so far, for example, last weekend, the first guy intubated was a 35 years old Asian guy. And so, you know, his only risk factor was asthma, and maybe he wasn't listening because he traveled to New York like early March. And he left San Diego and went to New York and on March 10th, and then came back on March 17th with symptoms. And then the other ones, he's the only Asian that I've encountered, but the rest of the other patients I've seen are Caucasian.
Interesting question, because demographic, hopefully we have more information, we will tell. Because I hope that, I don't know whether some different or not, but that would be an interesting talk. Hopefully next month we come back with more COVID. So right now, I would say the champion for tonight is Dr. To with 37 COVID patients.
For fun, you think after this, and Bao, you think many of the residents like whom gonna apply to be intensivists, or they're gonna run away from your specialties?
Yeah, I think the pulmonary critical care has been suffering for a long time. It didn't take this epidemic, but you know, people are shining away from this specialties. I would say a long time. Most of them go into cardiology and then hematology. These are popular in my program or other program. They go to cardiology, they go to hematology. Those are the hematology. Those are the top most common. And then most people then choose to be hospitalists. That's probably the third one. Once every 2 or 3 years, I will have one person becoming a pulmonologist intensivist. This is out of 30 residents. So it's pretty uncommon. I mean, it's become less popular now.
So especially in Bao, when you start to see your patients, there's, I know we didn't talk about treatment, but I'd like to see what your experience will be. You know, for one, like we have a protocol where we divide it.
So in order to kind of keep everything kind of a little bit uniform, because as you all know, there's no data behind, solid data yet behind hydroxychloroquine and azithromycin, and the other ones are really no answer. I think of the ones, let's list them real quick: hydroxychloroquine, azithromycin, remdesivir, right? Remdesivir, you can't get it in compassionate use anymore. It has to be in clinical trial now. And then tocilizumab is anti-IL-6. That's also has to be through clinical trials. So you really don't have a whole lot more. There's a few others. The anti-HIV, it's proven not to be effective. Carella, or something like that. The combination lopinavir. That's
Calitra and ritonavir. Yeah.
Right, ritonavir. That's not proven. That's proven to be ineffective. So that's out of our treatment protocol. Yeah. So now I'm not so much in control of it because the infectious disease are, and what they do is they put together an algorithm, and you can find these. These the Massachusetts General put their protocol online. You can find that. You can find it at UW too. But be careful because they update it every day, and then it's not necessarily what's on the web. So what we do is, personally, I don't put people on hydroxychloroquine or azithromycin, but it's in our protocol. So if another intensivist admits the patient and not me, chances are they're going to get on hydroxychloroquine and azithromycin. And so that's generally what they do right off the bat. The third thing, the other thing I haven't mentioned, and I have one experience with that, is we are transfusing convalescent plasma.
Yes.
So convalescent plasma, there's 6 patients. There's a series in JAMA that you published this week out of China. There's six patients. Our experience is a little bit different. Instead of a convalescent plasma, like people coming to the blood center and donating plasma and testing for antibody, the Nature paper is very very good to read because it's very condensed and loads of information. So antibody goes up, as we talked about it, 1 week, 50% of the IgM, and then peak at 3 weeks, and IgG come out. So they did find that they do find neutralizing antibodies, but the course of clinical course and antibody production does not correlate. So that's why it's a little iffy. If you give plasma, you give antibody, it may not make a clinical difference because the clinical course did not correlate with the quantity of antibodies that rises. So I'm crossing my
I'm just curious. Yeah, so I'm curious to see what your experience will be with your patients. So I've used, all of those except the plasma. I've used up to the we have Remdesivir in clinical trial and tocilizumab, which is kind of cool when I use it for the cytokine storm that the patient had, and they broke the fever pretty quickly. And then there's other things like the vitamin C and zinc, and which I don't think any of it's worked by the time I saw these patients. But one interesting that came up this week is therapeutic anticoagulation. So apparently there's some anecdotal evidence or some small case or from China that these patients are developing clots, and also some microthrombi that they think might interfere with the difficulty in oxygenation when you ventilate these patients. And so, I wonder what you guys would do, but some of the attendings here are starting patient on therapeutic heparin, Lovenox, not just DVT prophylaxis, but therapeutic Lovenox doses and heparin just to stay ahead of it and hopefully, decrease any clot burden. So I wonder how true that is too.
Right. So that's actually been debated too, discussed too, and I hear the same thing. And the autopsy report has shown microthrombi in the lungs. And one of the debates, why are these patients so hypoxemic, even though for the ARDS the compliance is not that bad. The driving pressure is usually only 13, 15. It's easy to ventilate them. It's not difficult. They're never hypercarbic. Because the desk space ventilation is not that huge. But why is it they're so difficult to oxygenate? And one of the theory is microthrombi. The folks who got Remdesivir actually got better. The two people that we got on very early on, young, very healthy, before they transition over to a clinical trial only, and we try to be in a clinical trial sites.
Let me ask you this quick question, Bao and Long. I'm sure you're aware of new clinical randomized control trial of Plaquenil from China on 62 patients. What is your comment? It's not yet officially public, but there is. Yeah. So what do you think about?
Well, number one, 64 patients is too small for this population, and it's hard to know. I'm not saying it's no use, but it's hard to know where to use it. Is it in the early on when they're very mild? There's also a randomized control trial going on right now in San Diego County, I don't know about elsewhere, among healthcare worker using Plaquenil as a prophylaxis. So you sign up, you're a healthcare provider, you either get placebo or hydroxychloroquine, and then they'll screen you, they test you, and they will see what percentage of healthcare provider will turn positive, will seroconvert. This is going to use serum. They will seroconvert at some point, and what percentage will not, and how many of those are on the placebo arm, and how many of those are hydroxychloroquine arm. I don't have a problem with that. I think that's probably pretty safe to do, because hydroxychloroquine is pretty safe medication in the first place. And we don't know where to use it, because is it in the early on, or is it when they're sick? Right now in my hospital, we're using it only when people are really sick. And is it the right time, or did we miss the boat?
My thinking is the timing could make a difference in terms of COVID-19 treatments. And I'm sure as an intensivist, you see when we intubate people, that's probably too late, right? I don't know if that's true, but the way I see when the cytokine storm happen, that's why we use Actemra. I think somehow, and the problem is when it's too early or when it's the right time, because you really want to get to when the virus start working on the innate system, because from what I'm seeing so far, it's interface with both the innate system and then adaptive system later, which is somehow they suppress the innate system in the first couple of days. So we don't have a correct mild response, and we usually do due to influenza or common cold. Now, I think that could be a good time to interfere, but the problem is who would be the optimal patient population and what time? Because the French study and the Chinese study, somehow, I agree with you, it could be just healthy. It could be just, I mean, without treatment, they can recover. Yeah. But 80% versus 50%, some statistical number different. I think there's something there. So hopefully, when we see next time, we have a lot to discuss. And I love this discussion because this is really get to the bottom of things, what actually working. Now, one question for you, Lon. There's a new medication called ivermectin. You know this, right? It's anti-parasite medication. And in Australia, they start working, do in vitro, not in vivo yet, but they found that they decrease significant viral load. What do you think about that, the ivermectin?
Yeah, I've heard, but I don't have any experience or any opinion on it. I haven't looked into it yet, but I'm still trying to do with the treatment regimen we have now. So we'll have to look into that. I'll take a look into that, but we'll have to see. Or maybe you can tell me what. You
heard about that too, right?
Yeah.
Yes.
So I've heard about it, but I don't know enough about it to tell you. You did ask me a couple of weeks ago about Colchicine.
Yeah. Yes.
So it's pretty much the same theory in that it might, if you give it early on, it may suppress the inflammatory response enough that delay the progression or even stop the progression to severe disease, to the cytokine storm that we're talking about. And I looked everywhere. There's no literature anywhere, but I know there is a professor in Montreal, Quebec, and his name is Dr. Tardif, Tardif. There might be two Fs. I think it's just one F. It's in Montreal, Quebec, and he's starting a study, and he's recruiting patients, and his studies, he's aiming for 2,000 patients. I don't know how he's going to get 2,000 patients, but he's looking for healthy COVID-positive patients compared to, Colchicine compared to placebo. And this is outpatient. So we may have an answer to that soon.
The reason I bring up Colchicine because I don't know if you recall a couple of months ago, there's an article in the Cardiology. So Colchicine is actually help. I'm sure you remember that, Dr. Luu. So it's amazing to me that a lot of old medication, we don't know, we don't care, but suddenly we look back how the mechanism and now Colchicine on the sudden it could be the next Plaquenil. I don't know. It's a lot of things. And then the one I just show you, it's old medication, nothing new. But the mechanism, it somehow is the same, anti-inflammations. Now, a question for you and Bao and Long too. Why we don't use Humira or Enbrel versus, is it because Actemra act particularly on IL-6 and that would be the bridge between the innate with the adaptive immunity? That's what I try to understand.
I think it's a fear of infection. It's a fear of superimposed infection. It's not that. Because you know that Humira, you can reactivate your tuberculosis. You're predisposed to other type of infections. I remember my early days when I was a resident and Humira came out. I got a lot of cases with like reactivation to TB and weird infections from patients starting on Humira. So I don't know when to use it. In the intensive care unit, we'll probably be too fearful to use it. Even that, the data is a mix, and it's very difficult to tease out because if you look at the Chinese handbook, you all got this. I actually seen that it translated in Vietnamese, translated 1,000 different languages. If you look at that handbook, I look through it, and what they say is, you know, rate of superimposed infection is fairly high, and they recommend, you know, empiric antibiotics and all of that. Our experience is opposite. We've not seen a superimposed infection, not until very late on. Early on, we don't see superimposed infection, and we get very nervous because they get the cytokine storm, and they have fever for days. So then we get nervous. We culture, we look, and we never find superimposed infection. But I think the reason why we don't use Humira is because of that fear, because we give it, and then when we find infection, then we totally are nervous about it.
Yeah, I agree. It's the immunosuppression effect from the medication that we're definitely worried about. Same thing with the tocilizumab too, is that, you know, that like one of the contraindication we have is transplant patients who are on immunosuppressive drugs, because then now you're suppressing their immune system. Can you fight the virus off, and then can you get that other superimposed infection on top of that too? And on that note, I do notice about that most of these patients that I get, they don't have a weight count. But
That's true.
When they do, yeah. So straight fever, like I've had, you know, 38.8, 39, even 41.5 Celsius, but no white count. You know, their white count's normal. The ones that actually has the super infections or have the superimposed infection actually do have elevated weight count. You know, go from 8 to 15 to 20, and I have one that now has MRSA. Pneumonia, and most of the pneumonia we end up having, I think you'll see too, is probably due to that, because they'll be intubated for quite a while, and then they ended up having that infection.
That's absolutely true, and this is a pearl for home. These are very good pearls here. Okay, so I've seen this almost uniformly, and if you look at the literature, it's 80-90% accurate. It's very, very true. It's very weird. They have lack of leukocytosis on presentation. They have lymphocytopenia. And some of them actually have thrombocytopenia, okay? And what I do is I always check, of course, routinely you should do a CBC on every day. I also check a procalcitonin level, and I check a ESR or CRP at the beginning, and I follow them. And what Long said is absolutely true. For the first week, everything is fine. And then, you know, day 8, day 9, you see the white count rise, and you see the procalcitonin level rise. And the fever is there. And then that's when you find a superimposed infection. But early on, they don't have it.
Wow. It's very... And I think there's a new paper come out. They also categorize this severity based on lymphopenia. So how low your lymphocyte count initially can somehow give a prognosis, right?
Yeah, that is true. Yeah, that's true. But don't mistake this for uniqueness for coronavirus. Actually, any viral infection that superimposed, overwhelming viral infection will give you lymphocytopenia. But they are trying to correlate the degree of lymphopenia with their prognosis, and that might be true. And actually, I've seen that in my patients who the people that start to improve are the people that get lymphopenia. The lymphocyte count start to rise, and they get better. But the people that don't are the people that get lymphocyte count as 500, 700, and then persistently low, and then they don't do so well.
Okay. Any other comments? I know everyone getting late, but I think this is great and Bao. So if you and Long and some of you here, I really invite you come back here, maybe 2 weeks or 4 weeks. Hopefully see how it goes. But this is so great. I don't know how you feel, but I feel this is actually one of the really best meetings in VietMD, because I learned so much and update from you guys from all US. So hopefully, and Bao, Long, and then Minh, and then all of you guys here come back for another sections. And I think at that time, I don't want to count who are the champions, but hopefully, and then who will stay on the hotel, because that's something. But hopefully, we learn from each other. This is great, and Bao, thank you for your insight. And Long, you guys are really give us a lot of insight.